This
patient
conference will now be recorded.
COVID-19 patient, because most of your patients will present with symptoms of upper respiratory tract initially, rhinorrhea, cold, cough, dry cough, and there could be fever also. So to differentiate, you'll have to have a high degree of suspicion. As it is, all of us are very stressed right now. We feel that every patient of cough or fever or cold is suffering from COVID-19. It is a possibility. And since this being such a highly infective disease, we have to ensure that any patient who comes to you with cough, fever, and rhinorrhea should be investigated for COVID-19. Now, again, it is not possible for us to differentiate or investigate each and every patient because the volumes are high, the system is stressed. As it is, the kits are limited. So my suggestion would be that the moment we find in the history is taken outside your OPD clinic, not inside your chamber. The patient comes, if the patient gives you a history of fever, cough, or any upper respiratory tract infection, travel history we take. Now, since the community spread has started, even the travel history is losing its meaning. So at least we maintain a distance of more than 2 meters from that patient, evaluate again. We must examine that patient with proper protection. Now, if we can see there is a cause for that upper respiratory tract infection, like there is signs of tonsillitis or signs of sinusitis, or apart from giving the usual medication, we should recommend that patient for a COVID-19 test. So ideally,
Yeah.
it is very
So very right.
difficult to
So
very
very
difficult
rightly said. So very rightly said by Dr. Samit that as near about whole world is getting into phase three community transmission. So if we are in phase three or anywhere in the world, is region is phase three, any common cold is we have to consider as COVID-19 and until proven otherwise. But in places like right now we are staying in Ranchi, so phase one and we are in phase one too. So we are not still in the phase three. So for us, how you differentiate, Dr. Atri, between common cold and COVID-19?
Yeah, I am speaking from the context of a place that is not yet seeing community transmission. So,
Yeah.
for such a place like Ranchi, Jharkhand, if the travel history is significant, or if there is a contact history, because it's very highly infectious, then these two should be pointers. Few facts which I gathered from international published literature is anosmia or a relative loss of smell. One thing was a out of proportion dyspnea or hypoxia not explained otherwise, and concurrent GI upset other than flu symptoms. These such things should alert us that this can be COVID-19. Thank you.
Yeah. And Dr. Puya, how your personal take on this topic? How you differentiate or how the things in
So,
Italy?
so thank you, Abhishek, for bringing me into this panel. So our point of view is a little bit different. We're doing the phase two, which means the reopening of different um, works, activities, social distances is mandatory, and mask use is mandatory, which is not so common in Europe. As you can see, not every state, not every country is adopting the same things. What we are facing right now on this phase two is that when we are approaching this phase, we are also approaching to the phase of impollination. So the things that we have to keep in mind is that sometimes during this season, we will see some allergic patients. So how do we differentiate allergic patients from normal patients or from COVID-19? This is a step two. By meaning of that, one of the things that is commonly seen in patients that are paucisymptomatic or mild symptomatic is that if you're facing different in loss of, or you're facing problems regarding smell or taste disorder or chemosensory disorder, which does mean For hearing loss, we are facing people that has suffering from sudden hearing loss, not only from gastrointestinal viewpoints, but also cough is not so common due to the fact that cough it's one of the symptoms that come in the first part of the disease, which is the non-typical pneumonia. As far as we know, the non-typical pneumonia is the first phase, then approaching as changing in a acute pneumonia from a bacterial one. So the thing that we have to consider is not only about symptoms which are runny nose or tonsillitis. Those symptoms become in a phase which is already been declared. The problem is that we also have to consider asymptomatic patients or those that are not being interviewed properly. As far as many of you are aware, the WHO didn't recognize until the 4th of May the problem with anosmia or difference in taste. So the interview were wrong.
Sure. Yeah, so rightly depicted, like I will just summarize whatever we have talked so far.
I just want to put a question up to Dr. Puya. So anosmia and dysgeusia, do you think they come first? Are there initial symptoms anosmia or dysgeusia?
The problem was this: at the beginning, the three parameter that was in mind of the WHO was cough, mild fever, and fatigue. Those symptoms were underestimated, because when you're developing cough, the first thing, and the fever, you think that it's completely normal to have disturbance in taste and smell. So the people wasn't be able to recognize those symptoms, and they were the super spreader. Because of this, then we realized that if anyone in this period of time is suffering from those kind of symptoms, by meaning of that is what we are faced after 1,800 interview in the last 2 weeks. The people are always telling the same symptoms, like they're in a place, like a working place, like doing work outside of an area, we're doing buildings. The nose, it seems completely not wet, but it's insensible to feelings. But it's not about the feelings, it's not a trigeminal sensation, it's completely different.
Yeah, so it's very good insight actually, Dr. Puya. Thank you so much for your input. So in community spread, we can't differentiate actually in I'm summarizing. And as like Dr. Puya said, anosmia, ageusia, and other sensory symptom also, like patients are presenting with only SNHL also in sometimes. And it's paresthesia on the face, inside nose also. So it's very important, the insight Dr. Puya has given. So we are going to the next question, very important.
There's one more thing here. So let us get this clarified, because Dr. Puya has given us some very insightful meaning into what should be the. See, now that pollen season is coming, now we're getting a lot of allergies. So what message to take from here, the panel, that we should not be scared of patients who are coming to you with runny nose, simply running nose, or just cough, which could be allergic. So let us not get very paranoid, and let us evaluate that patient and look for anosmia, dysgeusia, and more early signs of pneumonia. Right, Dr. Priya? And we can treat the normal allergic patients as a normal allergy patients.
What Dr. Puya, what you say? I'm getting stuck.
I think that if we are treating patients, usually can't hear you.
Yeah, we can hear you now.
Yeah, we can hear you now.
Hello? Oh, okay.
Lost.
Runny nose or symptoms that are sinus, yeah. If we comparing people with a history of chronic rhinosinusitis, those patients they're already aware about those symptoms. So we have to keep in mind that those people are always being treated with nasal douches, use of steroids or antihistamines. So if we are overlapping those symptoms with those from COVID-19, the thing is a little bit different. The people that are suffering from chronic sinusitis, they are, some of them are from the allergic ones, some of them are blockers, and some of them are sneezers. So if it's a sneezer people, if a sneezer patients come to us, we can already tell them to, first of all, use mask. Mask is very important. However, it is not mandatory. In Italy, it's mandatory the use of a mask. Then we could provide some tips for nasal douches. However, the nasal douches will not work in those patients because it's not sinusitis, it's a viral infection, and it's completely different from a coronavirus's usually typical flu, which is different. So runny nose, it doesn't mean that you're suffering from COVID-19. Usually, most of the patients coming to us are not having multiple symptoms. Sometimes you just can have one of those symptoms. How we can differentiate allergic patients from the COVID-19 is under review right now. So I cannot tell you exactly because we are studying it. So in the next few weeks, we'll have data and I will tell you exactly how we can do it or how probably can we manage some of these patients.
Yeah.
And what
Thank you.
about tonsillitis, follicular tonsillitis? Do you see that in your patients of COVID?
I have it one patient in end of February. One of them was completely abnormal for me. It looks like a mononucleosis, it's pseudomembranous tonsillitis. The problem was that no kind of antibiotic was them. They also
We've lost his voice.
Yeah. Dr. Puya, we have lost your voice. Dr. Puya? So we just have to, yeah, you just have to, no?
all right.
Yes.
Yeah.
Yeah. Now we can hear.
Yeah, I was saying that at that time, at the end of February, we weren't able to perform a PCR test in those patients. So those patients are just simply missed. But now we can do a serological test and re-examine those patients.
Mm-hmm.
Thank you.
So that's pretty good, but we are going to talk about the test and all those later. So my second question, like all of us are really in a panic state, especially like those where the community spread has not spreaded. It's the situation like us. So shall we start our OPD or not? So how you are doing, Dr. Puya? Have you started your OPD?
Yes, we started. The first phase was basically reserved for patients with advanced cancer states. And before anyone would have been operated,
Mm-hmm. We again have problem with your voice, Dr. Puya.
on
Hello?
of the surgery, also a swab. Every patient should always wear in the trains. Patients one that is candidate for surgery before the 4th of May were a candidate that's suffering from advanced or cancer states. Before approaching to the hospital, they should wear mask, even if it's a negative nasal swab test. And then from the room until the OR, they should wear mask. After that, every surgeon should use PPE and perform the surgery, even if in doubt for a COVID-19 patient, or even if the patient is COVID-19 free. The problem is that we weren't able to perform any endoscopic surgery because of aerosol, possibilities of spreading something, and even otologic surgery was not allowed to do it. After the probably next week we are going to start once again our operative room, also for some cases benign tumor, not simple like normal procedures.
Yeah.
What is your registered
Hello.
email ID? जो एयरटेल वालों के पास।
Hello. There is a background noise, please. Yeah. So, where is Dr. Narsaria? I can't see him. Dr. Narsaria, the pediatrician. Hello.
He was there on the panel. He must have gone somewhere. He's there. He's listening to us.
Okay. So, how's your take on Dr. Atri on it?
Yeah, we cannot postpone our OPDs indefinitely, and we must understand and accept that we have to live with corona, we have to live with COVID-19, however unfortunate it may seem. But thanks to researchers globally, we have got a understanding how it spreads. So if we can take these precautions, we should start our OPDs. There has been time for us to invent PPEs. There has been time for us to habituate people using the lockdown to wash their hands. So I think we should start our OPD with precautions, with the understanding how it healthcare providers and the patient and their attendants.
Yeah. So rightly said, and how your perception about it, Dr. Samit Lal?
See,
What about, yeah.
now important thing to understand, and whatever information we got from countries where it spread widely, the important thing is to understand is how this virus spreads. Now, we do not have any clear understanding on that. Right, Dr. Puya? We really don't know whether it is an aerosol spread or a fomite spread.
You've
Some
pretty much
studies
been
have
doing
shown,
it.
no. I found one study where it says the aerosol is actually
Yeah.
not the main way of transmitting. It's probably the fomites or on the surfaces. So, but yes, aerosol, if they are transmitting, definitely. And what they say is, like, if we keep a distance of 2 meters, chances of aerosol transmission really goes down, because these are small aerosols, and even while singing, speaking, uh, the aerosol will not spread beyond 2 meters. So if we are doing our OPD, important thing is first to protect our staff. We have to protect
Very true.
ourselves, and we have to protect our staff also. So that adequate distance maintaining for our OPD clinics, for our staff, for our pharmacy people is very important. Apart from that, using of mask for personal protection, and also mask on the patient. Even a surgical mask, if the patient, a suspect patient or a patient comes to your OPD and is not carrying a mask, even a surgical mask, waterproof surgical mask can be given to the patient in your OPD setting, so that you can examine that patient and allow that patient entry into your premises. We have to see patients, and like Dr. Puya said, that we have to differentiate between allergic rhinitis, sinusitis, and COVID-19 patients. The degree of suspicion should be high. We cannot just shut our OPDs and run away from reality. COVID is not going to just vanish into thin air. It's going to stay there for some time. So we have to ensure that we are protected, the staff is protected, and then we carry on our work. And then whomever we suspect, mild to moderate, should be put into isolation. Severe, of course, gets hospitalized. So we have to make a protocol in our OPD and ensure our safety and start our OPD.
So rightly said by Dr. Samit.
May I ask a point?
Sure.
I would like to reply to Dr. Samit. The problem is not the entering into the OR right now. We can safely enter into the OR and we can do the performance. The problem is that if we are treating patients for like endoscopic procedures or cancer, these patients will be immunodepressed. And how we can treat those patients after for postoperative management? If we taking care of the patient that has doing some endoscopic skull-based procedures, that means that for every time that we have to perform any kind of endoscopic medication, that will allow to propose and to expose us, because we will not see the patient after the procedures, and we cannot do a nasal swab after that. So endoscopic procedures can be allowed. The problem is that how we can manage postoperatively those patients. If the patient is going to be immunodepressed and he's going to stay in a place where his family had to take care of him, and unfortunately anyone is going to be with him that is exposed to the viruses, that would spread the virus to him, and then these patients from a normal state will drop to a state where he's immunodepressed, and they probably become very serious ill.
Yeah.
Right.
So rightly depicted. And how do you think, Dr. Narsari, about it?
Regarding my experience, especially with smaller children, we face issues that they don't allow keeping mask on their face. So most of the children, what we see, especially infants, those who are less than 1 year of age, the mask of that size is not available, and even they don't allow to keep mask. So what we are trying is we are calling patient on pre-appointment basis, and we're trying to keep a gap of 10 minutes between two patients, so that there is a minimum amount of people standing outside OPD or waiting in waiting area, because with a child there is at least two parents coming. So if you are seeing 10 people, 10 patients, then we have 30 people waiting outside. So what we have done is, yeah, so what we are trying to do is, we have our hospital number with patients, and we have our personal number, and we always give a prefix appointment, and we say that you have a 5 to 10 minutes buffer time. You have to come in that time. If you are late, then we might not allow you to enter our OPD, because children don't cooperate with wearing masks. It's only
So
parents who wear.
So I think that's also very appropriate for dealing with the pediatrics patient. Thank you, Dr. Narsari. So as like we discussed, so COVID will stay for some time. So take precautions at the level. Like Dr. Puya has reached to a different, and we are in a different stage, and take precaution and restart. So we are moving to the next question. So being a healthcare professional, should I take hydroxychloroquine for prophylaxis or not? What's your uptake, Dr. Puya, on it? What about the prophylaxis status in Italy?
I really like the prophylaxis that is approach in the Middle East, which is not mandatory over here. What we faced was there's no such differences in the outcome of the people that's suffering from COVID-19 and those who are using azithromycin and chloroquine. There's a randomized study that just came 2 days ago that I've got the opportunity to read, which is very interesting. There's no outcomes differences in those patients. I'm very surprised by the situation on the Middle East, and it's very interesting that how it's possible that BCG vax is something that is working very much, and as you know, in Italy we don't have a BCG prophylaxis. We don't do vax like this, and could it be a possibility that we develop such huge numbers? It could be a possibility. And
but actually, like BCG, sorry to interrupt, Dr. Yeah, but BCG also not been proven that it's really working.
I know. It's just a thought for me right now. I'm studying for it. We don't have the prophylaxis, and the problem is that the Ministry of Health is not recommending for everyone to use hydroxychloroquine. It's not mandatory right now, so the people are not using it every day, and so we are switching, and it looks like the Ministry of Health is pushing towards using plasma right now instead of doing prophylaxis. I'm aware that prophylaxis is it's essential. However, it's my point of view.
True. So yesterday night, Dr. Samir and Dr. Hiren will also join. Yesterday night, I was talking to them. So in the US also, they have withdrawn this HCQS prophylaxis in many places. And like Dr. Puya is also saying, there also it's not. In India, we have ICMR, and they have given a written guidelines that healthcare workers should take the HCQS prophylaxis, and we have been taking it. So definitely, like, we no longer. Hello, there is a lot of there was a lot of background noise. Yeah. So here back, as we were talking, so we were recommended by our ICMR in writing that healthcare workers should take the HCQS prophylaxis, but definitely there was not enough evidence that time. And now, as the more and more results are coming up, so the ICMR also may reconsider to taking this HCQS further or not. So we are moving to the next question. Testing protocol. So it's also a very controversial thing. So I will ask Dr. Puya that how the testing protocol right now in Italy.
There are three different protocols for one is the use of nasal swab. Second way, it's mandatory to use serological test. It's not the rapid test, however, serology is completely different. And then right now, in some places, there's also use of salivary test, which is recognized in IgA. Not everyone is admitted to do a nasopharyngeal swab. The thing that I'm seeing that's not everyone, not every region inside of Italy is doing the same protocol. Some of the places are doing oropharyngeal swab, isolated, and then they doing some of others are doing nasopharyngeal swab. The other thing is that when you are recognized as COVID-19 positive, the only chance to prove that you are free of disease is when you have the week before the first control swab, you don't have to report any kind of symptoms. So, for example, after 2 weeks, they will call you back and say, okay, are you feeling any symptoms? If you are telling them that you're not, and the whole week after you will have an interview every day, you will not have any symptoms, then you're candidate for the first nasopharyngeal swab or a oropharyngeal swab. If it's negative, the day after, then you have a nasopharyngeal swab. After that, some of the regions allow you to go back to normal activity or even at work. Other regions are not feeling the same, and then they say that you might stay at home for other 4 or 5 days, just to make sure that the residual amount of the virus is completely gone because of the gastrointestinal transmission or deposit.
So whom you are testing, Dr. Puya? All the people,
Usually,
or
candidates that are tested are those that are
there is a lot
referring
of background
symptoms.
noise?
Not
There is
me.
a lot of background noise, so not from your side,
Uh,
Mr.
so
Pradeep. Yeah, now it's fine.
it's the interesting thing is that they finally accepted my proposal for you might don't know, but we worked together for a Lancet paper that submitted to the WHO, and they finally recognized the use of the importance of loss of smell and taste. So the candidate for a nasopharyngeal swab are those that are suffering from a mild 37.2 fever, those with fatigue, cough, and also now disturbances in taste and smell. Those people can be tested, or anyone that should be candidate for a plasma donation, or those people that should do any kind of surgery or transfusion. And those people are candidates for nasopharyngeal swab, even if they don't have any kind of symptoms.
Oh, so
Very true.
like
Pre-operative, we definitely need to do a nasopharyngeal swab,
Hmm.
and
RTP.
like Dr. Puya pointed out, all cough patients need not go through a nasopharyngeal swab. They should have symptoms of anosmia, ageusia, along with fever. Then you send them for a nasopharyngeal. Patient is just coming to you for a cough, is not a
Yeah.
candidate. That could be LPR, that could be a lot of other things, allergy.
Right. So, like Dr. Puya said and Dr. Samit is saying, so basically there is a big difference. Like yesterday night, I was talking to Dr. Samir. He will join after 5-10 minutes. That what's the testing protocol over there? So he was telling that previously, because there are lack of testing kits and lack of infrastructure for testing also. So in US, there was very difficult to get tested. But now it's pretty easy, and anyone, whoever wants, either you have cough or not, you are just running. Today means in US, if you want today, look, I should go and get tested, so you can go and get tested. So protocol is basically changing a lot since last 3 months all over the world, and Dr. Puya has basically added about the saliva also and all those things. So what I am summarizing, so depend upon the availability of test and phase of infection. But the ideal thing is to trace the contact, isolate contact, and test contact. That's happening also, and especially in Ranchi, like we need to do the same. So
Yeah,
we
we
are
need to
moving to the
test,
next.
test, test. Use the system.
So I am moving to the next my question.
Sir, in between, sorry to disturb. This is Rajiv.
Yeah.
Dr. Hiren has joined us. Sir. Dr.
Okay.
Hiren, welcome,
Okay.
sir.
Pulmonologist from Florida. Yeah. Hi, Hiren.
Hey, sorry, I don't have. I'm working, so I'm on one of the random desktops, so it doesn't have a webcam.
That's fine. So,
It's fine. It's still a pleasure to
yes,
have you. It's a great
Thank you.
pleasure to hear your voice.
Thank you very much. Thank you for having me, all of you.
yeah. So, Hiren, I think probably you will be here for about 25-30 minutes.
Yeah, up to 30 minutes till 10. Yeah.
Yeah. So, let me introduce you the other guys. Dr. Puya is an otolaryngologist from Italy. Dr. Samit, otolaryngologist from Ranchi. Dr. Atri is respiratory medicine, chest medicine from Ranchi. And Dr. Praveen is the pediatrician from here.
Awesome.
So, yeah, so we were just discussing about the COVID. So my the next, so like you have also just joined, so I will ask you one of the questions. What the testing protocol they are back in US?
So, Abhishek, you are right. Things have changed since in the last month or 2 months since we have had testing availability. I think, especially when it pertains to you and like as ENT or something, we are actually testing everybody. So all our outpatient surgeries, patients are getting tested. All outpatient procedure patients are getting tested. All patients who are getting admitted in the hospital are getting tested. With regards to our ENT clinics, so I'm very good friends with a couple of ENT guys here, and they do indirect laryngoscopies in the clinic, which is considered to be an aerosol generating procedure.
Yeah.
And so it's hard to test all those patients because they are coming to the office visit. And so all of them are getting screened about standard symptoms before they come to the office. All of them are wearing masks. And then they figured out what the room turnover time is if you are going to do any aerosol generating procedure. And turns out that you need 12 air exchanges per hour. And so our ENT guys are, once they see a patient and once they're doing a procedure like an indirect laryngoscopy, they are letting the room vent for 20 minutes before they bring another patient.
Oh, so
Right. And that's a good idea, actually.
true. Yeah. And I was asking about, we just finished that we are taking HCQS prophylaxis here in India. So we just asked the Puya also, in Italy there was nothing like. So are you guys are taking any prophylaxis?
No.
Pre-exposure prophylaxis?
No.
Oh.
Just
So
PPE and that's it. No pre-exposure prophylaxis.
no pre-exposure prophylaxis. Okay. So the next question will be Dr.
No,
Yeah.
Abhishek, yeah, the gist is what Dr. Hiren is saying, that we can do scopies in our OPD setup, indirect laryngoscopy, with proper protection. And once we've done that aerosol generating procedure, we need to shut our OPD for 20 minutes and then
20 minutes, clean out.
20 minutes, and then bring in the next patient. So that is one
Yeah.
protocol we can add in our OPD settings, and that's a very nice idea, because you see, now you'll be getting patients with hoarseness of voice. So you need to do an indirect laryngoscopy. You can't
True,
just
true, true.
base your treatment on assumption.
True, true. So, Dr. Hiren, thank you so much for like adding those things in our day-to-day practice. Yeah. Thank you for adding it. So, my next question was from Dr. Narsaria, that how you are dealing with the children with flu symptoms.
Well, flu symptoms in children are pretty common. Children, on an average, below 5 years of age, acquire 10 to 8 episodes of upper respiratory tract infection, and they come with fever, cough, diarrhea. So we majority of patients they come with these kind of symptoms, but children have a somehow tendency of very low frequency of complications. So if we see that the other family members had a history of travel, or many other family members are having similar symptom, or they have came in contact with a COVID
With
patient,
yeah.
then only we encourage them to go for a COVID testing to family members, not to child, because sample testing below 5 years again is a difficult job, nasopharyngeal swab in child. So we are till now mostly I have not received patient. Those family members have admitted that they had been in contact with a COVID positive patient, or they had similar symptoms.
Mhm.
So we are not, and we are actively asking parents that did you had any loss of smell or change in taste also, or any GI symptoms, because in children flu-like symptoms are mostly associated with GI symptoms also, because the flu virus is a kind of that affects most of the mucosa, so it affects the respiratory tract mucosa and simultaneously also affects the GI tract mucosa. So we cannot go by the symptom that if the child is having both, it might be COVID. So mostly we treat them as a normal URTI patient. And if the family member have these kind of suggestions that they are all suffering from upper respiratory tract symptoms, and they might have some loss of taste, sensation, or abnormal smell, then we suggest them to. This is our policy here. This is what I am doing. But till now, I have not seen parents say accepting or coming up with a history of similar history of COVID positive contact or any other abnormal taste sensation. We are just treating them as normal URTI patient.
We should thankful also that the COVID is creating lots of background noise.
I think in children it is because the ACE2 receptors are not very well developed. Maybe that is the
Yeah,
cause.
yeah, that might be a cause, sir, definitely. And there is another marker what we I've been looking actively in children, that if they have obvious fast breathing, suppose they are if they're having obviously rapid breathing, or if the saturation is falling below 94 or 93% at room air, then we suggest them you should go for a COVID test. You should take a chest X-ray done immediately, and we also refer them to a COVID
So basically,
treatment center.
we are going to sort out those things. Huh? Dr. Munka, welcome. So, any questions, Dr. Munka? I can
Dr.
see Dr.
Abhishek, I'm
Munka.
sorry.
Yeah.
Can I
Uh, Hi,
can I interrupt
everybody.
you a second?
Just a minute, sir. Dr. Puya. Yeah, Dr. Puya.
Uh, I unfortunately I have to leave the
Yeah.
meeting, and I hope that it's not a big deal for me because I have some personal issue to take care of. And
So, so thank you, Dr. Puya. Thank you so much for giving so much input in our discussion. We really like enjoyed it thoroughly, and definitely it makes a volume that whatever you have given the insight to us. Thank you, Dr.
Thank
thank
Puya.
you.
you so much. I'm sorry for interrupting you, and I hope for you to have a great meeting.
Thank you very much for being.
Goodbye.
Yeah.
Yeah,
Thank
Dr.
you.
Munka, you are
Goodbye.
welcome.
Yeah. Can I get in?
Yeah, sure, Dr. Munka.
Uh, First of all, let me congratulate you for having a very excellent panel. The panel is good in the sense you have different specialty from different part of the globe. Having said that, most of us till now I was doing lot of reading about the articles. See, it is like situation is like I have put one of the this in the WhatsApp also. An elephant been seen by five blind people, and somebody says something and immediately people jump on it. Yeah, you are saying something. So still the things are not very clear. For but the thing is we have to live with it, as Samit has said. Most of the time we have to find our own ways. Number one, to protect yourself, which is very, very important, and to save your family from infection. Am I right?
Yeah, definitely, definitely. So I
So
will jump
in
just.
that context,
Yes, sir.
probably we have to find our own ways.
Hello, 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 hello. Dr. Munka, we can't hear you.
Yeah, we've
So,
lost.
so we are going to the next question.
To be
Should
a
we?
potentially in most of the centers 80% false negative report.
Hmm,
So for the precautions in the OPDs, I think whatever you do, first and foremost is a safe distance. That is very important. Number two, the exposure time should be less, and how you devise your process. Like few days back, I was looking at many of the articles. You isolate the patient, and today I am planning to start my OPD from Monday. I found if you get a transparent plastic sheet, something like microscope cover, you cover the face of the patient, let
hmm,
him wash his hands, then come to your OPD with a distance, and then probably, if you examine, there are hardly any chance of
hmm,
aerosol whatsoever is coming towards you.
hmm,
So, what is
hmm.
the opinion of the panel on this particular way of doing it?
So, sir, we actually discussed this aspect around 10 minutes ago, and
Yeah, I
basically,
was
Dr.
listening to
Puya has
that.
just left. Yeah. Yes, sir. And Dr. Hiren, he's a pulmonologist. He will be here for about 25-30 minutes. So we can just ask like very specific questions to him for a while, like
Yeah,
steroid and tocilizumab and all those,
Yes,
because
yes.
those things
Go
are
ahead.
under consideration. Then again, we will get back to it. So,
yeah, no problem.
yes, sir. So it will be just a small question from both Dr. Atri and Dr. Hiren, that should we continue to do nebulization in OPD, IPD or not? Dr. Hiren.
If the
Dr. Hiren?
Yeah, yeah. So, again, as all of you know, that nebulization is considered to be an aerosol generating procedure.
Yeah.
So we try to minimize it as much as possible. So just to give you an example, on our inpatient side, we are, like I
Uh-huh.
said, we're testing everybody for COVID. And if they're
Uh-huh.
COVID positive or they're unspecified that we don't know, then we are switching nebulizers to meter dose inhalers on all of them. On
Okay.
the outpatient side, only if they're COVID negative, we are doing on inpatient side nebulizer, or else we are switching everybody to a meter dose inhaler with a spacer. Um,
Mm-hmm.
on an outpatient side, like I do a lot of bronchoscopies, and we used to do lidocaine nebulizer on all these patients as a
Yes.
pre-procedural numbing, and we
Yeah.
have switched it. So we have stopped doing that, and we have switched that to just gargling of lidocaine, basically. In
Okay.
short, if we do not know the status of COVID, then we are avoiding nebulization, inpatient or outpatient.
So that rightly say that we should avoid aerosol generation as much as possible.
Yes, and I agree. I
Yeah.
think everything, if you can switch it to a inhaler with a spacer device.
Mhm. And my next question to Dr. Nasaria and Dr. Mehta also. So a lot of my patients wants to get vaccination for pneumonia and flu suddenly. What to do with them?
Okay, vaccination schedule are very clear for children below 5 years and adult patients below above 65 years. But
Mhm.
for them, pneumonia and flu vaccine are routinely recommended. But a
Mhm.
controversy comes for those who are above 5 and below 60 years. For
Mhm.
them, as such, there is no active guideline at present that vaccinating these children or these young adults with pneumonia or flu vaccine will help them against COVID. but these vaccines have not shown to be any harmful effect. So what we can do is, if the patient actively wants vaccine, we can offer them. But if he asks, the patient wants to know whether it will be helpful for me against against COVID. As of now, there is no recommendation or guideline. That's
Okay. Thank you, Dr. Acharya. So, what about the temperature and latitude, Dr. Lal, in COVID spread? So, does like the high temperature is hello?
Yeah,
Hello.
whenever there is a fomite-based spread,
Mhm. So, Dr. Atri, yeah.
yeah, whenever there is a fomite-based spread, high temperature will definitely be favorable for us and unfavorable for the virus, because any fomite gets inactivated or sterilized at high temperature. Same for subtropical latitude. But again, if you look at the global spread, and a very burning question that whether summer is going to save us, if you look globally, there has been different spread in different countries, there has been different mortality in different countries. So ultimately, it all boils down to precaution, precaution, precaution.
True,
Dr.
true.
Samit
So,
Lal?
like, yeah. So, like yesterday, also we were discussing, like in Russia, it's such a cold country, and total number of case has jumped up to like more than 2.5 lakhs. Uh, the
And in
mortality is
Middle
definitely,
East,
yeah,
Iran is warm. They've been having above 40 temperature since the last 2 months, and still the virus is spreading rampantly.
true,
So
true.
again, that is why there confusion coming in whether it spreads through mostly aerosol or spreads through fomites. Now, as if it's only spreading through fomites, then warmer countries would be saved. But then
True,
it's not happening. And there have been places where it has been suggested that no, aerosol is not the mode of transmission. It's on the surfaces for days and then it's transmitting. So we need to have a proper research there, and people are researching, but we still do not have definitive answers there. So
so definitely, like we stood in the precaution, precaution, and precaution.
exactly. So you have
So
to
my
take
the
precautions
next question,
where you are.
yeah. So the next question is threshold for doing a X-ray test or CT scan, Dr. Hiren.
So, in short, the answer is high.
Uh-huh,
If you have symptoms suggestive of COVID, then you should
uh-huh,
test them for COVID. Now, CT scans are, the problem is chest X-ray. I think if you have shortness of breath or if you are having hypoxia, all of us would
uh-huh,
agree that they would get a chest X-ray. But CT
uh-huh,
scans, we are actually having a very high threshold unless you
uh-huh,
think there is an alternative diagnosis,
uh-huh,
like a pulmonary embolism or a lobar pneumonia or something. We are not doing CT
uh-huh.
scans. And the reason is, one, you transport them all over the place, so you expose a lot of people. And the second
True.
reason is that your CT scanner then goes down for more than an hour because they will have to clean out everything, let the room vent,
Uh-huh.
and it may not change your management or it may not change what you do, kind of thing.
Okay, so like here, what we do, like if SpO2 at room air is less than 94%, then we can consider like CT scan, because there are a lot of people having silent hypoxemia patients.
Mm-hmm.
So in that case, especially like hospital and inpatients, whenever we try for the, we have little difficulty in Ranchi about the testings and all those things. So
Now, I
if
would
some
like to
patient
ask
is,
a question, Abhishek, sorry, to Dr.
yeah,
Hiren. Do you think X-ray chest could be a screening tool for patients of COVID?
I don't know, and I don't think there's any literature. There is some literature out from China about CT scans and how
mhm,
CT scans, if you see ground glass opacities with interlobular septal thickening, the sensitivity is more than 90%. It's even better than your nasal swab.
yeah,
But
that's
that was
what, yeah,
actually
I
a
read.
very small study from China.
Mhm.
Um, but I don't think it's being validated. So again, like I said, if you have testing availability, I think the best thing is to test them. And
True.
Right.
digital X-ray.
If
And
not, if not,
one more question, Abhishek, I would like to ask Dr. Hiren. Do you think pulse oximetry in a routine OPD setting, like we do a thermal scan, should we also do a pulse oximetry in patients and entering into our outpatient department?
I mean, we routinely do it, so I think it's actually a good
That's a good idea.
practice. overall,
Yes, sir.
regardless of COVID or not.
Right.
Okay.
Thank you
And
very much.
especially like there are so many patients of silent hypoxemia in COVID.
Right.
So we can easily like scan through the routine pulse oximetry. So
Correct.
thank you, doctor. Yeah, thank you very much. So my next question is, Dr. Atri is there or not? No.
Yeah, I am there.
Yeah. So how should we manage allocation of manpower in
Yeah,
hospital?
yeah. Whenever we are planning to take in COVID patients,
Mm-hmm.
there should be a ward preferably designed at the
Mm-hmm.
periphery or at the exterior of the hospital where we can
Mm-hmm.
keep the COVID patients, and the
Mm-hmm.
staff attending that area should be confined to attending that area only. Such staff
Mm-hmm.
should not be rotated to rest of the hospital.
Mm-hmm.
And the staff attending that area should be in
Mm-hmm.
double strength with half attendance so that they
Mm-hmm.
can be rotated if one of
Mm-hmm.
them unfortunately gets contaminated. In
Mm-hmm.
fact, in our city also, the
Mm-hmm.
hospitals currently which are taking COVID patients mandated by the government, their wards
Mm-hmm.
are at the periphery of the hospital and not
Yeah.
via multiple corridors. Single
Mm-hmm.
exit, single entry, and not intermingling entrance with other wards.
Mm-hmm.
So that is something sensible.
True, true, true. So Hiren, how you people are dealing there?
So I agree. I think cohorting the patients is one of the most important things. So
Okay.
anybody who is COVID or not only COVID positive but suspected COVID, we are
Mm-hmm.
cohorting them all in one or two locations. So we have a designated ICU location and a designated, regular floor location.
Mm-hmm.
So patients who get on ICU get to a designated ICU, and patients who get on floors get onto a designated floor. With regards
Mm-hmm.
to manpower, again, it's always important to have a small group of people who are rotating through, like Dr. Atri said. One
Yeah.
is because they, you don't want a lot of your staff exposed to this wards and fall sick. But second is that group of
Mm-hmm.
people, the highest risk to the healthcare worker is when you put the PPE on and you take the PPE off. And so you really want people who are well trained and know exactly how to put the PPE on, and more importantly, how to take it off.
True,
To be in that ward. If you have multiple people who don't know how to take PPE off, that's where the highest risk to the healthcare worker goes. And so you want
true.
a small number of people who are well trained, know how to
Mm-hmm.
don and doff PPE, um, rotate through that ward, and you should cohort all those patients.
That's excellent. Yeah. So we are moving to our next question. So are you guys at, it's to Dr. Hiren. So are you guys taking any post-exposure prophylaxis?
No, we are not. In
Okay.
fact, we have moved on just along the same lines as your last question. Is that
Mm-hmm.
initially when we started seeing COVID patients, we
Mm-hmm.
started saying that if you get exposed, you
Mm-hmm.
go into self quarantine for 14 days. But
Mm-hmm.
in a couple of weeks, we realized that we would put almost half of our hospital in self quarantine if we did this policy. So we immediately changed the policy so that even if people who are exposed,
Uh-huh.
they continue to work with a mask on as long as they don't have symptoms, but they will get tested at day 9 and day 14 and just make sure
Uh-huh.
they're not positive. But there is no post exposure prophylaxis. People who have exposure continue to work at our place with a mask
Mm-hmm.
on and continue to monitor for symptoms and then get tested at day 9 and day 14.
Yeah, pretty much I think in Ranchi also we are going to have the same situation like you guys are over there. Yeah. So the next question I will move. So it's a very interesting question, especially for
Uh,
Hiren.
Abhishek, Abhishek,
Yes,
can
sir.
I add a point about the manpower planning you were saying about just now?
Yes,
In
sir.
Bokaro Hospital, which we have a dedicated COVID ward, where the
Yes, sir.
positive cases were brought by the district administration. So what
Mm-hmm.
we do for our staff was, we got two doctors in each shift. We
Mm-hmm.
made a group of doctors. They do work. One doctor, two nurses, two ward boys. Since the load was around 7 to 10 cases, and
Mm-hmm.
they do two shifts. One comes
Mm-hmm.
in the morning from 6 to 2 and 2 to 10, something like that. So they come
Mm-hmm.
in the three shifts. After 7 days, they are
Mm-hmm.
kept in a hotel. We have engaged hotel rooms for those staff. That we don't want them to come from their home and go back and infect
Mm-hmm.
everybody if they are positive. Then they
Mm-hmm.
stay in the hotel for 14 days still two negative tests are there.
True.
So
So,
that is
Dr. Murtha,
protocol we
yeah, yeah.
follow.
So that's excellent protocol. But if the caseload is less, we can definitely follow what you are saying now. But like what Dr. Hiren is saying, if it is too much, then we can't have basically the that kind of prevalence.
But you have to protect your
All of them
staff.
have to basically true, true. But all of them
You have
have
to
to basically
protect your
jump onto the
staff. That is very important. And
ground.
the studies have shown the more affected medical persons with a severe degree are not from ICU and OTs, but from the OPDs and the ward, IR. That is the main thing we have to consider.
True,
And
true,
so
true.
it is a very tricky situation.
Mhm.
That is correct.
Ve-
I would strongly recommend that for people who have not seen it to go to the CDC US CDC website and see
Yeah,
how to put the
Yeah.
PPE on and how to take PPE off. I think that's very important.
very important, very important. Yeah, I went through and that the Ebola, especially that post Ebola or whatever they have put, that's really like fantastic. Yeah. So my next question is Hiren from you to you. So what novel therapies can be a potential candidate for avoiding ICU transfer? Like I am talking about uh, role of like remdesivir or early steroid intervention. So we can basically prevent the ICU transfer of the normal mild to moderate patients.
Yeah, just like the slide says, there is nothing proven so far. Um, we used to start all these patients on hydroxychloroquine and azithromycin, but after
Yeah.
a few studies that showed it didn't help, and even in our practical experience, it did not help, so we stopped doing that. Um,
Hmm.
we because actually we on the contrary of what you say, we actually avoid steroids on these patients. Um,
Oh.
yeah, so in fact, if our COPD patients who come in with COPD
Hmm.
exacerbation
Hmm.
with COVID, we are actually not even giving them steroids because
Oh.
there is some data that steroids actually
Immune
make things
mediated. Yeah.
worse. And so we have even tried to avoid inhaled steroids on these patients, not even systemic
Uh-huh.
steroids. Um,
Oh.
with regards to remdesivir, I mean, it
Hmm.
may help. We don't know. We just don't have remdesivir. Like, we got promised by Gilead that they will give us a load of remdesivir, but we haven't received any. I think it's in short supply all over the world.
Oh.
What we have been doing is we have been enrolling all these patients in clinical trials. And so we
Uh-huh.
had a study we just concluded about sarilumab, which is just like tocilizumab. It's an IL-6 inhibitor.
Yes.
And we enrolled all our patients, any patient basically who needs oxygen on sarilumab
Hmm.
trial. And now we
Hmm.
have a couple of other trials which are opening up. One is the lopinavir, ritonavir with interferon beta,
Yeah.
and there is another study. So basically, there is nothing proven. So we are just enrolling them in clinical trials so that we can get some data.
True, true.
But
So I have also
it's
one
basically
question.
symptomatic management. It's basically good symptomatic management.
Yeah. Like many cases, like the pulse oximetry can speak about the silent hypoxemia patient. And once we know that, okay, he's a walking patient having not much problem, but when we are seeing the O2 saturation at 74%. So what are the precautions basically we can take in such walking silent hypoxemia patients?
If the patient's coming to your OPD,
Yeah, and
yeah,
suddenly,
I
like
think
on the pulse oximetry, we came to know that okay, he's
mhm.
having gross hypoxemia. Yeah, and but
I
he's
think the
walking. He
most
does not have any symptoms.
yeah the most. I mean, certainly, I would assume that you're going to admit that patient. Um,
Okay.
but regardless, I think the most important thing, which I think is universal precaution, like taking care of yourself and your staff. And so, regardless of what this patient's pulse oximetry is, I would recommend that any patient who's walking through your OPD,
Hmm.
it's a mask put on. Um, every
Yeah.
person should have a mask put on. And I
Then,
think that's the
uh,
single biggest thing that will protect the healthcare workers when the patient has a mask on.
true. So I am
And
means I am assuming that all the persons are following all the guidelines for proper PPE,
that is
and then
correct.
after I am talking about yeah. So right now, like very
Yeah,
specific questions to you. Yeah.
if I want to talk about the management of this patient,
Yes.
happy hypoxemia, walking into my OPD, in current
Mm-hmm.
scenario, I have to assume this is COVID, send a
Uh-huh.
test, definitely admit this gentleman or lady, and
Mm-hmm.
as per trials or literature all over, what we are seeing is early intubation is leading to mortality. So,
Mm-hmm.
if possible, keep this patient on high flow oxygen, non invasive ventilation, proning of the patient, early proning of the patient, and bed rest and adequate hydration. See,
Mm-hmm.
any viral infection can be a storm if the body resists. If you
Mm-hmm.
can keep the body at rest, if you can minimize muscular activity, if you're
Mm-hmm.
not challenging the virus, then the storm will blow over. The moment the person or the body starts challenging the virus, the problem
Mm-hmm.
starts. Try to
Mm-hmm.
delay intubation as much as possible. And even
Mm-hmm.
in India, I talked to certain colleagues in Madhya Pradesh, Maharashtra, and Kerala. They
Mm-hmm.
actually delayed intubation and leading to success. The, the patient
So,
started improving from third to fifth day.
mm-hmm.
So I will
Hmm,
Yeah,
go over
chime
to
in,
Dr. Hiren.
Abhishek.
Yeah,
Um,
Dr. Hiren.
so we actually don't follow that. In fact,
Uh-huh.
non-invasive ventilation generates a lot more aerosols, and so
True.
most of the hospitals across United States, non-invasive ventilation is a no-no. It's considered to
Oh.
be a contraindication on these
Uh-huh.
patients with COVID or suspected COVID because you are putting your healthcare staff at a lot of risk because of the aerosol generation.
True,
Um,
true, true.
so high flow itself generates a lot of aerosols. So if you're going to put them on high flow,
Yeah. Yeah.
definitely put the mask on, keep the mask on the patient with the high flow
Mm-hmm.
on. Our protocol for a while has been that our oxygen escalation algorithm has been up to 6 liters on nasal cannula. If patient needs more than that, then we put them on a Venturi mask. After that,
Mm-hmm.
we put them on a non-rebreather. And
Mm-hmm.
after that, if we suspect that there is going to be a rapid turnaround, then we put
Mm-hmm.
them on high flow. But if we suspect this patient's in for long haul, then we intubate them.
Oh,
Because I agree that one, you want to treat the patient, but at the same time, you want to take care of your healthcare staff and you want to do anything that you can to minimize aerosols.
true, true, true. Yeah. So always no to non-invasive ventilation
That's
because
what
it's
all
generating
over
so
the
much,
US,
so much,
that's the standard policy. No non-invasive ventilation in these patients.
because it's generating so much aerosol. Yeah.
That's correct.
One more important question to you, Dr. Hiren. So, how the things about tocilizumab and steroid? When you prefer steroid, when you prefer tocilizumab? Especially, I am talking about in India because tocilizumab is costly medicine and steroid is pretty cheap.
Yeah.
So we can for the future aspects, like we can use steroids rampantly over the tocilizumab. So, how's your personal experience on both?
So we try to enroll them in clinical trials first. If we
Hmm.
cannot enroll them, then again tocilizumab is expensive here too. But we are
Okay.
giving them tocilizumab. Like I said before, we are trying to avoid steroids.
Hmm.
Again, there is very little data. I think there are small studies from China which have shown that things can get worse with steroids.
Hmm.
And so we are actually trying to avoid steroids. But
Hmm.
other than that, I mean, sometimes we have this knee-jerk feeling that we have to do something or give
True.
something, but that
True.
may not be necessarily true. I mean, with any other viral illness,
Yeah.
it's just good medical management and good nursing care and good respiratory
Hmm.
care, and you just
Uh-huh.
let them get over the tide, kind of thing.
True. Yesterday, no, means not yesterday, a few days ago, I was talking to Khalid.
Hmm.
He's in Arakan's, also maintaining the ICU over
Hmm.
there. So his
Hmm.
personal experience with steroid was better than the tocilizumab.
Hmm.
But definitely, like there is no RCT done, so it's like all personal.
Hmm. Yeah.
Yeah, Dr. Samit, you were
Some
saying something.
papers, isolated papers coming out of France and Italy and even China, where they said before the patients develop acute respiratory syndrome symptoms, they have used steroid for a short period, and they, because of the steroids, maybe anti-inflammatory action, the patients have not progressed to ICUs. So there has been some studies regarding that also, but then it's not validated and they're very small studies. So we really don't know whether, short-term use of steroids can be used or not, because long-term definitely we cannot, because it's an immune suppressive drug and already the immunity is compromised. But yes, maybe for a short period before they develop symptoms, maybe for 2, 3 days, 5 days, I don't know whether it's a good idea or not.
Yeah. So Dr. Hiren is like not very pro steroid because
No, I mean,
Mhm.
we don't know, like Dr. Lal said, we don't know whether it works or not, and
True, true,
definitely what you don't want to do is cause harm. So
true, true. That's the rule number one. First
that's
is
the rule.
no, yeah, yeah, no harm. And another one of the recently, like few papers has come about the pulmonary thrombosis. So, are you giving the Levonox prophylaxis as soon as you are taking the patient means the patient is coming to ICU to
Yeah,
prevent
so
any thrombosis?
there
Yeah.
is a lot of talk about it, and a lot of
Mhm.
hospitals across US have developed protocol about it, and so we have tried to develop protocol too. But what I will tell you what other hospitals, some of the major centers protocols are. So
Mhm.
all patients, they said, should get DVT prophylaxis, and
Mhm.
that means that's Lovenox 40 milligrams once a day,
Yeah.
subcutaneous. If and these are just protocols. Again, there are no studies. Then
True.
they
True.
divide the patients into low risk group, intermediate risk group, and high risk group. Low risk
Mhm.
group gets DVT prophylaxis, intermediate risk, and they call intermediate risk group as any patient who has a D dimer of more than 3.
Mhm.
And
D
they give
dimer of
them
more than.
D
Mhm.
dimer of more than 3, just one cutoff
Mhm.
criteria. And those
Mhm.
patients get a medium dose or an interim dose Lovenox, which is 0.5 milligrams per kg,
Mhm.
ideal body weight, twice a day. And then they classify the patients into high risk group, and high risk groups are something that we all know, which is patient who has
Mhm.
known blood clots, known DVTs, a mechanical
Mhm.
valve, so anybody who would deserve anticoagulation anyways.
Mhm.
And those are the patients who get full dose anticoagulation, which is either a heparin drip or 1 milligram per kg Lovenox BID. But these are
Oh,
all protocols, and we don't know if it helps or not. But
yeah.
the one that I told you, is actually the most accepted protocol by a lot of hospitals across United States.
And actually, it makes sense also. It's not basically giving the patient any harm. So, yeah. So my another question, Dr. Hiren, to you only, what is role of plasma therapy? Recently, like we are hearing a lot about plasma therapy,
Hmm.
and few patients are getting cured, but few patients not. So
Hmm.
actually, how it's yeah. So your insight about the plasma
So
therapy?
we have given plasma, I think, to around I think 10 or 15 patients, convalescent plasma by now.
Uh-huh, uh-huh, uh-huh.
And you know, to be honest with you, I don't know if it works or not, because these patients who are
Oh.
getting it are like sick, on high
Mm-hmm.
PEEP, they are prone, and so it's like really a Hail Mary kind of a thing. You're giving them
Oh,
everything, and you don't know what works or what doesn't.
true.
But
So
the
it may
way,
be like tocilizumab or a steroid or
yeah,
plasma
you
or
don't know, because you are
yeah,
giving them
yeah,
so many
yeah.
things that you don't know if it works or not. But what we are doing
Mm-hmm.
is, so United States, the FDA, the Food and Drug Administration, because it's not approved indication,
Mm-hmm.
they do what they call the EIND, which is basically investigational new drug approval. So anytime you want to give plasma to one of these patients,
Mm-hmm.
we have to call FDA. FDA grants permission to use it. Then
Oh.
we ask our blood bank. They
Mm-hmm.
are very good about it. They grant permission in 6 to 12 hours. And then
Mm-hmm.
we ask our blood bank, because the blood banks don't have convalescent plasmas, a lot of blood
Mm-hmm.
banks. And then sometimes they do, and sometimes they don't. If they do, then
Mm-hmm.
we consent the patient's family to say this is investigational and this is not standard of care. And
Mm-hmm.
they sign it, and then we give them the convalescent plasma, typically 3 units of plasma,
Mm-hmm. Mm-hmm.
just once. And that's it,
Oh, so 3 units of plasma just once.
just once.
Oh,
And I'm assuming that even in India, it's in short supply. I don't think you're going to be able to get convalescent
true, true,
plasma
true.
easily.
Yeah, very true. But like initially, like in India, like few days back, we were hearing that the finally like this plasma is working in all tough cases. But then after
No,
like when the more
one
data came and Dr. Atri was
only
saying something.
one out of only 1 out of 10 patients are able to get that plasma due to the short supply. So
Yeah,
they
it's
need
very
to
hard.
try. So they need to triage it for people who are unlikely to survive. Second, who are critical with some lesser comorbidities with a chance to survive, and give it to them because of
Hmm.
the short supply.
Mhm. And how is basically outcome so far?
I think you read multiple papers out of United States that
True.
once they get intubated, their mortality is anywhere between 50 to 90%. So, I mean, the outcome is terrible regardless.
Whatever you do. Yeah.
Yeah, I mean, we try everything. We don't know it works or
Mhm.
not. This is just like a Hail Mary kind of thing.
Mhm. And what about like so remdesivir basically you guys did not get, and whatever
We don't,
place like they have got. You were saying something?
no, yeah, we don't have it.
Okay. So what's normal routine protocol you follow for your patient? If some patient has come into the ICU,
Hmm.
uh,
Hmm. Yeah,
having hypoxemia?
it's basically standard protocol that you would. Sorry.
Yeah.
It's basically standard protocol for ARDS management, really. Um,
Okay.
it's basically I told you about your oxygen escalation. Try to keep them
Mm-hmm.
dry. Don't flood them with fluids. We do give
Mm-hmm.
them till we know whether they're truly COVID or not. And even once we do, I think most of us have a very low threshold to do broad spectrum antibiotics for
Sure.
any superimposed pneumonias or infections or something.
Mm-hmm.
Um, we make sure everybody has adequate PPE. We do early proning. I agree with that.
Mm-hmm.
Early proning,
Okay.
and if they go from non-rebreather to high flow, then we have low threshold to intubate them, prone them. And once you start struggling with hypoxia, even with proning,
Uh-huh.
then we have paralyzed them. We have done inhaled vasodilators like inhaled prostacyclins.
Mm-hmm.
And we had a couple of patients who actually went on ECMO.
Mm. So I heard like ECMO so far means the prognosis if somebody has gone to ECMO, it's extremely worse.
It is, but I mean, we had a 22-year-old nurse who survived
Uh-huh.
after being on
Uh-huh. Oh,
ECMO. So
congratulations. Congratulations.
yeah, yeah.
Really great one. So early pruning means how early pruning?
So we do as soon as the P to F ratio goes less than 150. Some people even do
Mhm.
200. They prone them.
Oh, so that's pretty good. So the next question is what blood parameter can be done before sending for COVID-19 RT-PCR if suspicion of disease is low? So,
D-dimer, ferritin.
mhm,
Well, the parameters what we can do is there were different. Initially, it was thought it's a viral infection, so they
mhm,
would have some parameters like CRP will be elevated. Procalcitonin can also be seen, but in adults,
there
response
is
to
no
of
rise.
CRP. Hello.
So CRP is
Uh,
rising, but procalcitonin is normal
But in,
basically. So,
but in pediatric patient, the scenario was different. They had a more higher rise of procalcitonin compared to
oh,
CRP. And moreover, we can get a differential count also done that helps us differentiate that is it a bacterial or viral infection. This
mhm,
can be helpful to us. Otherwise, in a systemic viral infection, we also see elevations of SGPT and SGOT.
mhm,
ESRs are essentially normal initially. So we can
mhm,
actually order a total and differential count, a CRP and a procalcitonin initially if the suspicion is low. This
mhm,
might help us to somehow point whether we are dealing with a viral infection or a
mhm,
pneumonia. And if the patient is a child and the procalcitonin is elevated, but the differential count is pointing towards a viral infection, like lymphocyte
mhm,
count are elevated, neutrophil response is low, then we can consider it as a COVID infection. And
mhm,
in adult, if CRP is elevated pretty high, depending on
mhm.
lab parameter, it should be elevated above at least 2.5 to 3 times of normal cutoff
Yeah.
of that lab. Then and the differential count is again suggestive of viral infection, and then we can suspect it might be a case of COVID.
Hey, Abhishek, I have to leave. If
Okay.
that's okay with you. But
Thank you.
I'm
Thank you so much,
yeah,
Hiren.
sure.
Really
Okay.
like your inputs.
Thank you, Dr.
Outstanding.
Yeah,
Prakash.
thank you,
Really
Dr.
great.
Hiren. It was
Okay.
great having you.
Thank you, Dr.
Thank
Hiren.
thank you for
Thank you,
having. And
Dr. Hiren.
listen, I posted my email on the chat web. If
Mhm.
any, like, we can talk. If any questions, I'll be happy to share protocols or connect or whatever. I'll be happy to help.
Thanks a lot.
Thank you,
Thank
Hiren.
you very
Thank
much.
you.
All right. Thank
Yeah.
you. All right. Bye.
So, so we already discussed all these, and we discussed this part also. So, last question is reinfection with COVID-19 after recovery. Uh, Dr. Atri?
Yeah.
Mm-hmm.
Given the controversial nature of the disease and the very early data,
Mm-hmm.
it's very difficult to say because in India up till now we have not found any patient of reinfection, whereas in
Mm-hmm.
China they have reported some patients like that.
Mm-hmm.
Again, the tests to establish reinfection are still dubious up till now, but anyone who has recovered from COVID should still continue with the precautions so that this risk may be statistically 15 to 30% does not turn to reality.
Mm-hmm.
Again,
Yes,
I would like to say that COVID is like a flu virus infection.
true.
It's kind of, and annually we do give flu shots to every patient.
Sorry
So
to
it's not
sorry to
kind of.
interrupt. Dr.
So
Samir has
reassort
arrived.
potentially. Oh, Dr. Samir.
Hello,
Uh,
guys. Good morning. How is everyone?
Hi,
We are
Good
Samir.
fine.
morning.
I can't
Morning.
see
Hello,
you.
Dr. Samir. Great to have you here.
How are you guys?
Great.
Pretty good, Dr. Samir. We were just waiting for you. So Dr. Hiren came here. He just left, and
Okay.
Dr. Puya, yeah, he left in between. So Dr. Samir, there were some questions from you also.
Go ahead, guys.
How long you are going to stay with us?
I have 20 minutes.
Okay. So my first question from you, Dr. Samir, is how the testing protocol there?
Testing protocol. Wow, that's a loaded question to start off things. So, it depends. Number one, the availability. So right now, today is what, Thursday, May 13th, May 14th here in America. Anybody who wants to get tested can get tested. Anybody who wants can get tested. You don't even need a prescription right now. You can
And
walk
how the
into a
situation was 2 months ago?
Now, 2 months ago, very different. Now, 2 months ago, when initially this thing came out, there was a very short supply. We were only testing people, number one, those who were symptomatic, and number two, who were essential, quote unquote. So my patients were doctors, cops, nurses, people like who meet other people and are critical to the economy and the society. We were testing them. Now, with a higher availability, whoever wants to get tested can and is getting tested. Having said that, last week we have a commercially available antibody test, and now a majority of my patients are asking to be tested for that.
Mm-hmm. Yeah, thank you, Dr. Samir. My next question
Yeah,
from you is
1 minute, Dr. Abhishek.
yeah, Dr.
Based on this rapidly changing testing protocol, I would want to quote the Bhagavad Gita that what was an absolute contraindication in the past may be a relative indication today and may become an absolute indication in the future.
True.
That's true, Dr. Ratri. So my next question is about HCQS, Dr. Samir. Because in India, like ICMR has given a guidelines for pre-exposure prophylaxis of HCQS to all healthcare workers. So
Right.
are you guys taking HCQS prophylaxis or not?
So great question again. So, in the last, I want to say 9 weeks, my first patient that I saw face to face who 3 days later tested positive was, I want to say now 10 weeks ago. From that point onwards, myself, two of my partners, and everybody at the hospital, none of us here took any pre-exposure or post-exposure prophylaxis by way of a pill. I know some of our colleagues were taking hydroxychloroquine in India, very common. Nobody did it here. What we did all do is diligently use our PPEs. So you can see I'm sitting in my office. This is like a small room here. Nobody comes here, but I have 2 masks on. When I step out, I have a face shield on. Wash your hands repeatedly. Don't touch your face. Wipe down your phone. That I think is the best pre-exposure prophylaxis. Now, post-exposure prophylaxis, God forbid you develop symptoms, 95% of people will do just fine. Rest, fluids, Tylenol, Mucinex. If you get sicker, God forbid, then you need hospitalization and so on and so forth. But there is no pill people are taking just for the heck of it.
Oh, that's fantastic. And yeah, Dr. Amit, go ahead.
Sir, Dr. Samir is not visible.
Oh, am I not?
Yeah, sir.
Yeah, Kaise, how do I start the video here?
Sir, there is a camera button at the bottom, sir. You're using your mobile, sir.
Please share. Sir, you will have to share your video. Please share your
There
video.
you go. Good? Better?
Yes.
Yeah, now you are visible.
Fantastic. Yeah, fantastic. So thank you so much for letting us know about the HCQ status.
Yeah, Abhishek, can I just ask one question,
Yes, sir.
Dr. Prakash Munka? Yeah, I
Yes, sir.
wanted to ask Hiren also, but since he left, before Samir leaves, Samir, I have
Uh-huh.
got certain things to know because many of my families are in US, and
Sure,
they
go ahead.
always discuss about many of my families are in US, and we
Sure.
keep
Mm-hmm.
on discussing the
Mm-hmm.
lockdown in
Uh,
India vis-a-vis US.
correct.
So I wanted to know what is the effect, number one, in the containing the disease, number of cases, number of deaths, and what will be the future course. So what is your take as a first person from American health team? I wanted to have it.
Dr. Kumar, I hope everybody is doing well from your family. Again, this is a great question. I'll tell you why.
Yeah,
मेरी भी जो family है, my college friends, they are constantly talking about this. क्योंकि लॉकडाउन करने
yeah,
के बाद काफी लोगों को बहुत परेशानी हुई है. People have had a lot of problems. Not getting
yeah.
into the politics of it, not getting into the
Hmm.
politics of it, I think lockdown eventually will save a lot of lives in India. Now, does it have a cost? It has a huge cost. मैं भी न्यूज देखता हूँ, the poor migrant workers and shopkeepers and whatnot. Now, the mistake that America did was we did not have a severe lockdown early enough. 2 weeks ago or
Yeah,
3 weeks ago is when a mask became compulsory. 3 हफ्ते पहले तक you could go to a grocery store and
yeah.
not have a mask on. अभी क्या हुआ है?
Hmm.
85,000 people are dead in America. A rich
Yes.
country like America, that many people died. यहाँ people के houses, no exaggeration, are bigger than entire mohalla in India, and फिर भी people die.
Yeah.
अगर इंडिया में मोदी साहब ने ये लॉकडाउन नहीं किया होता, in my humble opinion, we would have already had hundreds and thousands of deaths, because this is literally an infectious disease. The only way to
Yeah.
stop the spread is to contain it. Now, having said that, you cannot lock down the entire country forever, right? अभी आप पूरे देश को तो बंद कर नहीं सकते. तो जब देश
Yes.
खुलेगा and लोग मिलना जुलना चालू होंगे,
Hmm.
तो unfortunately, it's gonna go up. Now, काफी सारी theories है. वो BCG वैक्सीन, अपने इंडियंस की इम्यूनिटी, अभी गर्मी से
Yeah.
कुछ फर्क पड़ेगा, I don't know.
Yeah.
But I think doing the lockdown was the right thing to do when he did it.
Yeah.
Dr.
So,
Samir, there is still, when we read, more you get confused.
Uh-huh.
So what I feel is right now, whatever theories are coming, किसी को
Right.
कुछ नहीं पता what is happening.
Correct.
Basically, one drug works for some people. They come out with a hypothesis. This is the drug, just
Right.
to dismiss after a few days.
Right.
Like hydroxychloroquine prophylaxis,
Correct.
much cited. Many people started taking, and there were mixed reports.
Correct.
So similarly, once in India, we already had more than 50 days of lockdown.
Right.
After that, once it is open,
Right.
what do you think the course will be? Course means
So,
number will increase definitely, but
right.
will the virulence will be less or something more, or is it just delaying the disease?
I mean, like number one, मैं आपको बताऊं, this is what I tell all my patients. Every day I tell it. I've been telling it for the last 2 months. This is a new disease. This is
Yeah,
a new virus. So doctors are
yeah,
learning at the same time as patients. So if
yeah.
somebody asks me, कि 6 months के
Hmm.
बाद, what's going to happen to my lungs? I tell them I don't know, because nobody has seen
Yeah.
it. What happens? Now, the,
Hmm.
the the most I've seen patients is 9 weeks out. So I can tell you what happens up to 9 weeks, right? Now,
Yeah,
why am I saying this?
yeah.
95% of people will do just fine with supportive care. The
yeah,
usual suspects are diabetes, age, looks like male gender. My older men did the worst. 3 of my
yeah,
staff members were positive. Young girls, young women, they all did fine. A few
yeah.
days of fever, some cough, but they recovered quite fast. Actually, they're back at work now. So
Hmm.
95% of people are going to do just fine. The
Yeah,
5% of people are going to be, again, the older people, the diabetics, people with heart disease, hypertension, and men. Now, out of those, what are you going to do? It depends upon what their symptoms are. Prone position, everybody is doing it. Delaying
yeah,
intubation, I'm sure Hiren spoke about that.
Yeah.
We
Yeah.
are not
He did.
giving hydroxychloroquine anymore. Steroids are
yeah,
back in use now. Remdesivir, mild to moderate, we are doing that. My hospital is trying the plasma therapy. The jury is still out there. I don't have a conclusive data this way or that. If there is a way on this group, I'll
yeah,
share the data that we have. And these are the options. Now, God willing, in a few weeks to few months, we'll have a therapy. And in 1 year to 18 months, we'll have a vaccine. But we are not there yet.
What about the community? Something they say community immunity will come when the number of cases will high. What is your take on that? Something
So,
I just could not understand.
right. So if you read New York Times had a, go ahead. I'm sorry. Dr. Lal, you were saying something?
No, absolutely. Herd immunity has happened in other pandemics, and you, you can tell us about what information you have, Dr. Samir.
So, herd immunity is a fancy term. What does that mean? A lot of people in
Yeah.
the community have gotten it so that the transmission less goes down. Now, New York Times has an article this morning that in France, which was hit quite bad, you'll be surprised, only 4% people actually got the infection. So, इतने बुरे हाल हो जाने के बाद भी 30,000 लोग के खत्म हो जाने के बाद भी only 4% of the population got the virus. So they are nowhere close to herd immunity. Now, if we wait for herd immunity with a mortality of 3 to 5%, अपने इंडिया में 130 करोड़ लोग हैं, 4-5 करोड़ लोग खत्म हो जाएंगे by the time we get herd immunity.
Yeah, already in India the mortality is 5 to 8%.
Mortality, yeah.
5 to 8% in India, the current mortality.
Yeah, yes, that's what I was going to add on that. Yeah. So,
I mean,
so right now, I think the best thing is to just to protect yourself by the taking care, and personal care is more important than any other care. Do you agree with me, sir?
Yes. So as far as like physicians, we have to have PPE. That's our role. Wash your hands, wipe down your phone, mask, and all that good stuff. What can general public do? 6 feet दूर खड़े रहो, हाथ दो, खांसी है तो घर पे रहो, wear a mask. If you are
vulnerable. हमारा specialty जो है ear, nose, throat and dentistry, I think probably they are very prone because we cannot see from a distance of 6 feet. Sure. That is the problem.
Dentists here in NJ basically last 8 weeks completely closed unless it's an emergency because they are very high risk.
Yeah. And they have been said it is a non-essential services, but ENT we cannot close down because there are many general patients.
You have to have a good quality full headgear.
Yeah.
So Samir, my one question. You have
been okay, please go ahead. I have taken enough time now.
No. Thank you, Dr. Munka, for such a relevant question. Yeah. So Samir, I have one question from you.
Go ahead.
So you have seen so many COVID patients so far.
Correct.
And you have been saying since last 2-3 months, but you have protected yourself.
Just Dr. Yeah. She keeps calling. I don't have it here. Probably on the I don't see it over there either. So I'm out in 5 minutes. We'll fax it in 2 minutes. Yeah. Good. Sorry about that.
So what medications basically are you taking? Vitamin C or something else for yourself?
Oh, good question. Yes. We all are taking vitamin C. Everybody's taking zinc. A good night's sleep, 8 hours of sleep. This is not the time to watch Netflix, just so that you have a good immunity. I'm taking vitamin C and zinc. Yes.
So no HCQS, vitamin C and
and zinc.
And any other like personal precautions you take? What's your takeaway message for that?
Again, the third time already. Very careful with my PPEs. So I even wash my glasses. I wipe down my phone. I wipe it again once I go home. I don't touch my phone unless I've wiped it down once I'm home. I'm using a separate car to come to the office. I don't share it with anybody else. I wear this thing because it just catches the fomite. Then I'm wearing scrubs inside. I stopped wearing tie and shirts and pants. I'm wearing scrubs. They go into dry laundry and whatnot. When I'm seeing patients, I have a very good quality PPE. Then I'll have this one on. I'll have a face shield. When we were rounding, we are not rounding anymore in the hospital last 2 weeks. We even had those PPEs which cover the rest of your body and so on and so forth. Basic stuff really, but do it religiously.
True.
Basically protect yourself and build up your immunity. That's the only lesson we have.
Yeah.
Correct.
Yeah. So anyone is having questions? to anyone.
So I think I'll take off, guys. Dr. Ramadin, thank you very much for this opportunity. Guys, take
Thank you,
care.
thank you,
Yep.
thank you, Dr.
Yeah, thank you, sir. It was very illuminating. Thank you.
Yep. Thank you very much. Take care, guys. Bye now.
Bye.
Bye.
So, any other questions from audience or anyone else? For anyone? So, I think we really had a great discussion together.
Yeah.
Yes, sir. Samit, sir?
I think in the chat box also what people asked, we've already answered them.
Yeah.
Yeah,
So I
we
think
have
Vijay
answered all the
Choradia sir
queries.
is asking, yeah. One question Dr. Vijay Choradia sir is asking difference between the isolation and quarantine. So Dr. Atri.
Yeah, quarantine is for people who are exposed but not yet diagnosed with the disease. Isolation is for someone who has been diagnosed with the disease. So quarantine is a preemptive thing that before we know that we may develop the disease, that is quarantine.
Yes. And Dr. Choradia has also asked about the vaccine trial. So definitely not just 6 months, because I was talking to one of my friend, Dr. Sachin Jasawal. So he's basically a virologist working in IIT Guwahati about and he's also in charge of vaccine for corona. So he's working through the parainfluenza virus, I think, measles virus as a backbone for coronavirus vaccine, and most likely his vaccine will come up somewhere in after 9 months. So we were talking
Yeah.
about the Oxford vaccine, and the basic
Can I add a
drawback.
pinch of salt over here?
Sure.
The best doctors or the best.
Just let me finish about the Oxford vaccine.
Sure.
Because recently, like we talked a lot about the Oxford vaccine. And they have started manufacturing also without proving the basically efficacy, and the trial also not been over. So the basic problem is going to be with the Oxford vaccine is the backbone of the vaccine is adenovirus. And with the adenovirus, there are high likely chance after a couple of years after the vaccination, the person can develop couple of cancers. So how safe actually that vaccine? Like in short time span, it could be very safe, but long time span we can't see. But virologists know that what the basically the basic drawback, and that was the suggestion of Dr. Sachin Jaswal from IIT Guwahati, that if the Oxford vaccine will come into the market, and if it will be given, there are high likely chances of having malignancy after a couple of years because of that Oxford vaccine. Yeah, you were telling something.
Yeah,
Dr.
what I see is that the best brains in medicine pick up pediatrics like Dr. Praveen or ENT surgeons like Dr. Samit, Dr. Abhishek, or some become pulmonologists. But now I would want someone to make a vaccine for me to be safe. So we really need to introspect that the best brain should become microbiologists, virologists, biochemists, biotechnologists, and in fact, money or finance in medical research has been very short funded. After this COVID, this needs to change in India as well as worldwide. Currently, we need people, we need the best brains in vaccines, which is not there.
No, I think
Maybe
we
the
have.
world needs to change.
The world over, there are very good people who are working on vaccines, very intelligent.
So my like friend, Dr. Sachin, he's having so many more than 25 fits in
Abhishek, in a lighter vein, if we say in a lighter vein, the COVID started from the virology lab from Wuhan. So we should keep that in mind as well.
No, this should never be in record. This should be only in lighter vein, not on record.
Yeah, that's what I said. So we have to be the guidelines and the checkups, checks and counter checks are very important for such research. That is my point.
Because it is an RNA virus. See, we've not had a vaccine for HIV since it's been like 40 years now. HIV, it's an RNA virus.
And we are living with it. Yeah.
Vaccine for RNA virus is very difficult.
Measles is also a RNA virus, and
but you found for it.
So right now, that's what I was talking about. My friend, that's Dr. Sachin Jaswal, he's working backbone measles virus and preparing this vaccine. So I think we should not be basically very pessimistic also about it. Very optimistic that probably we will have vaccine by 1 year.
Israel has come up with Israel has come up with an antibody dose against COVID virus. Now, I would
Yeah.
like to highlight one point. These external antibody dose basically work on the basis of an expected infectious agent load. There is a certain amount of dose has to be calculated, which will neutralize the expected amount of infectious agent load in the body. According to that, the antibody dose is prepared. The vaccine which Israel has made, it's basically antibody, and they're saying that it will kill the existing virus, and something will be left short of that will also prevent from future infections against the virus. But I
Yeah.
have a serious doubt about what will be its implication of the dosage on pediatric versus adult versus a geriatric patient. Because again, the dosing pattern in pediatric and adult are different. And those people who are comorbid, they will have a different clearance rate of the chemical antibody what has been given to them. So again, a flat dose, what they're prescribing, probably it's a 5 ml dose that has to be given flatly to everyone. So, and
True,
antibody has,
we have no awareness for the viral load.
True.
yeah, that's what I
That's the most
what I was trying to say. That vaccine has probably been approved, and it might be mass manufactured. And like
so the
Dr. Abhishek pointed out, one vaccine that has an adenovirus backbone. Again, vaccines have a lot of influence on our immunity, and they play a lot with our immunity. Suppose we know that as far as I know, BCG vaccine has a lot of implication in our immunity, which we don't know. Many aspects we don't know as of yet. So accepting this vaccine, because very soon we'll facing patients in our OPD. If a vaccine is approved, suppose that Israel vaccine or any vaccine, people will be coming to us and asking, should we take this vaccine or not? That will be a very difficult situation. As Abhishek sir pointed out, this adenovirus backbone might have a long-term implication. So I
after
don't
five,
know
6 years,
how.
you may end up into some cancer. David from
Yeah,
COVID has
because
died.
I have to vaccinate patients frequently, so I frequently face a lot of question regarding vaccinations. Like, how will this vaccine behave in my child's body? How long will be protected? Will he never acquire any disease related to these vaccines?
True, true,
So,
true. Very true.
any vaccine takes a, like for dengue, we have Dingvaxia that yet to be approved for commercial use. It has been approved by WHO, but yet it has not been
We
commercial
get a
use.
lot of vaccines.
We don't dengue for more than 5 years, at least for more than 5 years. So this vaccine against COVID has been prepared at war level. What my personal opinion still stands that we should not recommend this vaccine, even if it's been out in market. We should
True.
still say कि you should practice social distancing, face mask, and frequent hand washing. As a doctor, if a new medicine is introduced in market, we should be the last to use it. We should be the first to know about the medicine, but we should be
Yeah.
the last person to use it, because when side effects appear, especially when we are working in our country, people will straight away blame us rather than blaming the approving authority about vaccine. They'll say कि आपने तो बोल दिया था, इसलिए मैंने लगा लिया, अब ये परेशानी हो गई, it's on your head.
So that's very important point. Even like vaccine will come, they are coming with a very short-term trial. And what are the side effects? What are the basically it's going to on our immune system, or what kind of cancers those vaccines are going to create on us? Nobody knows, because the trial will be very less period of time. So the take-home message from all panelists and the guest panelist also is PP, PP, and PP. Use social distancing, use PPE, protect yourself. The most important thing is right now, protect yourself first and protect your patients.
Build up your immunity. Have a lot of vitamin C, D, whatever vitamin you can lay your hand on.
Adequate sleep,
Eat
adequate sleep.
Yeah, eat
At least
healthy,
8 hours
sleep healthy,
of exercise. Yes. 8 hours
and
of
namaste.
I think the most important still remains the social distance. Gap,
Yeah,
gap, gap, and no direct
yeah,
contact. Like if there was a study, if you are putting mask, patient is not, or both are putting, and the other way is missing. So that is the what is the transmission rate. So that's what I will present someday back. Today only I started trial that. I am having a disposable sheet which patient puts into his face covers it, something like a polycap which we use, and it is a transparent, so we can see all the examination, and frankly speaking, no aerosol into the atmosphere. So that I will be trying since from Monday, and I will share with the group. It was a
Great
nice
idea, sir.
discussion.
Thank you.
Yeah,
Thank
thank
you,
you
Dr.
very much,
Yeah.
Abhishek. And I think
Thank
you
you.
gave me enough opportunity to talk. And I have not taken anybody's time, I'm sure.
No, thank you,
Yeah,
everyone. Great moderating, Dr.
Thank you.
Abhishek. Thank you.
Thank you,
Thank you
Abhishek.
all.
Thank you, Aditi.
Thank you very much,
Thank
sir. Thank you very much for joining from my side, sir. Thank you so much, sir.
Thanks
Thank
a
you.
lot, sir. Thank you very much. What a great session, sir.
Thank you all. Bye. Have a nice day.
Thank you very much.
Bye.
It was a great
Thank you,
session,
sir.
sir.
Thank you, sir.
protect yourself.
Yeah, we
And if
request to
anyone is having
Devasis sir.
huh, if
We
anyone
request
is having
Devasis sir to
चलेगा चलेगा शायद
चलेगा.
I'm writing my email
अच्छा.
ID. If anyone is
Okay, हम
having
बोल
any question or concern,
हाँ हाँ
I
बोल दीजिए सर.
देवाशीष sir is in the group.
gmail.com.
अभिषेक sir,
हाँ बोलिए. मैंने अपना email
sir,
ID लिखा है. हाँ सर.
on behalf of McLeod, excuse me,
हाँ. Go ahead, sir.
on behalf of McLeod, really, sir, we are thankful to our moderator and panelist, guest panelist. Really, sir, today my words are not enough to express the gratitude. On behalf of McLeod, once again, I would like to thank our moderator who graced with his thought-provoking and make the interesting this discussion. Really, sir, once again we are thankful to your presence and also our panelists. At the same time, I must mention our deep sense of appreciation to all of you, all my colleagues, medical team, and PM team.
The team McLeod for
Things
doing
world
this.
cannot be or can touch, but felt by her. And such words,
Thank you
such
very much.
prayer among